All right, just a second here. All right, so again, thank you guys for joining us this morning for our PFE kind of Train the Trainer event this morning. So this is kind of a continuation of a lot of the PFE work that we've been doing before. So, but we welcome you guys to be here with us as part of the first part of this series. So just kind of a call out for you guys is that this is going to be an interactive kind of day for us. So I'm going to pose some questions to you. And as we go through today, feel free to put into the chat box or to take yourself off mute and pose questions or comments or things like this. This is really more intended to be a dialogue among colleagues. So, and making sure that we're all on the same page and that we're moving forward together with that. So for our short time today, we're going to talk about how PFE is currently being measured and promoted throughout TCPI. We're also going to describe the value of PFE, person and family engagement, and talk a little bit about how we can talk about return on investment without getting really deep into the weeds and getting into a white paper or the big articles for it, but how can we talk about it when we're sitting with our practices? And then we're going to help select and overview 2 metrics for focus for our person and family efforts as we go through the next quarter together. So just a quick iteration, I think a lot of us that are on the call here work with a lot of person and family engagement every day, but we see some names on here that are newer or maybe a little bit, you know, have been working some other areas for that. So we always want to talk about what is person and family engagement. And I really love this word cloud because it really pulls out those components. And this was something that was put together when they asked a group of providers and a group of patients, what is person and family engagement? What does it mean to you? And when I look at this, the biggest thing that I pull out is a partnership. When I work with my practices and with my providers and patients about PFE, what I focus on is it's a partnership. It's not just one thing. It's not about what we're doing to or for our patients, but what we're doing with them. That reciprocal relationship that's built on trust, open communication, and there's responsibility on both sides. I also want to hone in on the fact that when we talk about PFE, we all get really into the data. We focus on what our clinical quality measures are. We hear it from CMS. Our providers hear it when they are reporting their information so they can get payment from whether it be CMS or Medicaid or a private payer. But the important thing when we're working with everyone is to remind them that PFE is not a standalone. PFE is already integrated as part of what we do because every single tally mark, everything that we look at with data, all our quality improvement efforts, all correlate back to a patient, to someone's loved one, to ourselves. And I think it's really important when we work with our practices and we talk about PFE and they say, why are we going to do this? Why am I going to look at those metrics or measures? You know, it kind of feels like fluff to them, is to try and remind them that PFE is actually the center of everything that they're already doing. It's already their priority. So a quick gauging poll for those of you guys that are on the line. How familiar are you with person and family engagement, or PFE? So we've got kind of a Likert scale here with 1 being not familiar, 3 somewhat familiar, and 5 very familiar. So please go ahead and enter into the group chat kind of how familiar you are. And this is just something to help us. We've got some upcoming slides that kind of go through some of the background of what PFE is. And depending on where our audience is, where we're all at today, determines how, you know, how much time we'll spend on that. So I expect everyone from a 1 to a 5 across the board. This is a safe space.
Wow, looks like we have some all-stars. Good job, guys.
Super exciting. Okay, we've got a lot of 3s and 4s. We have some 5s in there. So that's kind of where I expect everything. So the really cool thing with this is that with the ROI conversation and our next step with the rest of these education series, I think we're going to be able to speak to those folks that are maybe at that 3 all the way to where if we've been really honed in on this, how can we do it better? How can we step that up? So thanks, everybody. So PFE in practice, just something really quick for those of us that might be a little bit further up to a 2, is to remember that PFE is a primary catalyst in healthcare transformation. When we are talking about PFE, we are not just doing it because of TCPI or because of MERA. PFE really does fit into that value-based care component, regardless of what aspect you're coming at it from. But I think it's also really important that we talk about even the joy in practice. When we talk about PFE with our clinicians in our practices, is to remind ourselves that why did we all get into healthcare? And it was for that person aspect. We wanted to help people. And so being able to bridge that in, and that is why it's a catalyst, because not only can we invest and get the buy-in from that side, but at the heart of everything we do is our patients and how they interact with us and what they do when they leave us. So PFE is our way of supporting them throughout that experience of care. The other thing that I always like to really make sure that we're all aware of is that while PFE is kind of, there's a vigor of interest here right now, it is not brand new to us. So we have been working through this process already for years. There's already a body of evidence, there's experience that's there, including our work within the Partnership for Patients. So especially within TCPI and the PFE work that we do, a lot of that started with the experience in the hospitals when we first started to look at person and family engagement. And we started to look at how could we measure, how could we capture that, and what are some of those key small pieces that we could implement that were really going to drive that change. Again, knowing we all have limited time with our patients. So if we're going to invest time, resources, and energy, how can we make sure it's the biggest impact for both ourselves and our patients? So it's also through the Partnership for Patients that we've started to really, when we talk about that return on investment, started to see that higher performance where hospitals at higher PFE performance actually were showing higher performance in their clinical outcomes as well. So that relationship that tiers in together with that, that we look at those things. So acknowledging that PFE, we are all on the same learning curve. So even those of us that are at that 5 for understanding and recognize that, there's a whole progression. We continue to move in this field. And so I just wanted to give you guys a quick visualization again to show the PFE learning curve. You know, we started in the 70s with some of this language when we were doing the health maintenance organizations. It's really important in the ACOs. I don't think anybody's, surprised by, the PCMH movement that's there as well. And then again in 2011 is when we started to take it, and it was kind of these theories and these ideas and started to say, okay, how do we really capture and measure that? And it has progressed all the way through to TCPI. But I think one of the things, if you look at this, when you are going back and trying to reinforce PFE and its role in what we do, is the AHRQ Guide to Improving PFE in Hospital and Quality and Safety. So that is really important, and why it's included on there is because that was, again, another catalyst for why this became something that wasn't a silo or something that's offset, but really became something that's integrated into the work that we do as a whole when we look at patient safety, outcomes, and satisfaction. And of course, we have our own TCPI aims and drivers. And when you look through this, we kind of look at it and say, okay, so when CMS said, what are going to be the key things that are going to change these practices, especially our practices that just by the nature of being eligible to participate in TCPI tend to be a little bit further back on the change curve. But when we look at that transition to value and not just surviving, but really being able to thrive in it, that primary driver is patient and family-centered care design. They could have gone with those evidence-based practices as far as how do we specifically manage diabetes or chronic care, but no, they recognized and called out patient and family-centered care design and person and family engagement as that primary secondary driver in that. So again, just a reiteration for how this fits into what we're already doing. And I just want to hone in on the fact that while sometimes it feels like we've got all these other barriers, this is going to be the thing that actually helps us to get to our other intended targets. So PFE, when we think about it, a lot of times when we look at it, I want to make sure that we are looking at it from a holistic perspective, rather than thinking of person and family engagement as, we did it with a patient satisfaction survey, or we gave them a brochure, or we did some of these different things. I want to make sure that we all have the same understanding of person and family engagement as part of a process together. It is a journey that we take with our patients. And while we look at this, we look at it first, and it comes to that primary point of care, that communication. This is where we consider health literacy and shared access to information. So when we think about our metrics, this is where it comes in, that point of care, those initial points where we are leveling the playing field, making sure that we each have the same access to information and we're able to make decisions based off of that. And as we develop those relationships and we hone in on that communication beyond the smiles and, the plain language, but really how we interact and build those, that's where we get to engagement. So that's kind of, again, the progression of step as that trust relationship builds. where reciprocal communication happens. So it's not just us or providers having to give out the information, but patients are actually feeding some of that back, some of those teach back mechanisms. They're sharing information back. So if they're doing home glucose testing and they're sharing that, they're going in, they're putting it in their patient portal, or they're writing it down and bringing it back into their visits with that. This is also where when we make the invitation to our patients, and we do that a lot of times, we make that invitation, we say, okay, we put it out there, we're waiting, we're expecting our patients to respond back and clamor up on that, you know, that kind of that, if we build it, they will come mentality. Well, they're not going to come unless they feel comfortable and confident in being able to accept that invitation. So as we engage our patients, that's kind of the progression that we go on. And again, as this relationship continues to develop, this is where we get into empowerment. And this is where we start to make a little bit more of that difference, where that activation starts to happen. They believe in their role. They have self-efficacy. They think that they have a place to do it, that it's appropriate for them to share back, to question, and that it's their role when they go home to follow through on that. So their care is something that happens beyond their 15 minutes with their provider. It's also a willingness to be part of the shared solution. So again, it's where they start to engage in more dialogue, where rather than just waiting for their provider or their health coach to tell them what to do, they're more willing to participate. So again, when we talk about shared decision making, this is another key area where they start to get activated, and it's through this empowerment that our patients start to recognize their voice. So when we talk about some of our metrics, so when we talk about a PFAC or a quality improvement groups, this is where that kind of starts to where they start to recognize that they have something to add into this. And then there's the allowability then to participate in a variety of different mechanisms, whether or not it be part of a PFAC or if we're working on a quality improvement effort. And so we ask them for their feedback. Hey, you know, Doris, we're working on this. What do you think of that? This is also where they actually start to fill out those surveys. So any of us who have worked with the surveys, we get a couple back, and you know, we maybe get 20% of the surveys back that we send out. So are these patients that are a little bit more in that empowered component that are willing to fill those out and get them back to us, so that even as we're including the patient voice, if we go from that point and we're integrating it, this is where they're coming from. And the end target of engagement, it's not that end, is to have patient activation. And really what patient activation is going to be patients who are equal partners. They're participants in their health. Proactive versus reactive. So they may, if they start noticing a change or they're not feeling quite right, rather than just waiting for their next appointment, they may call in and say, hey, you know, I think maybe I need to see someone, or they might put something in their patient portal to communicate that. There's greater adherence and follow through on treatment plans. So again, these activated patients feel empowered enough to carry through with their treatment plans and recommendations when they get home, whether that be their medication or an eating plan or an exercise plan, or a referral community-based resources. There's a variety of those different things, but this is where those activated patients come in, and we start to see that really engaged, equal participant role in their care. It's also really important that we call out that each one of us is also a support for others. So we aren't just saying person and family engagement is a broad breath here. It's to recognize that not only do families act as caregivers for the patients we're working with directly, but our patients also act as caregivers for their children, their loved ones. And their influence on others. So more activated patients are able to extend that role as they look at their kind of what I call their care circle. So, you know, as we look at patient activation and engagement, the main thing that we want to make sure that as when we approach our practices and we're working through this is that we are not doing it based off of a simple metric. We're saying that TCPI is telling us we have to do this. There is real value in these processes. So a lot of these things tend to be a little bit low tech, high touch. But we know as we kind of go through and we have kind of evaluated patient activation engagement, we know that more activated patients are less likely to have a hospital readmission. You can see from the graph here that less activated patients have a 28% higher chance of being readmitted to the hospital within 30 days. 36% of those are also more likely to experience a medical error. They have poor communication between their healthcare providers. And one of these components for this also is that with the patient as part of our team, it's also a set of extra eyes and ears that they can call out and say, hey, I thought we discontinued this medication. Am I still supposed to be taking this? So again, it's one of those extra avenues. So it's not just how we provide care and if we can avoid error that we have control over, but again, it's their responsibility, that proactive component, and being part of this with us. You also look at a 47% increase in suffering a health consequence because of poor communication among providers. Again, they can be the or not the catalyst, but they can be kind of that baton between providers because, again, they're the only consistent across their experience of care, from provider to specialist to home into the community. And so they're an incredible resource because they get to see all of those vantage points. And the last one that's on here that I always like to hone in on is the loss of confidence in the healthcare system. So if a patient doesn't feel engaged, they don't feel as though they are invited and that they get to participate in their care, they have less confidence in their healthcare system and their treatment. This is really important because when we talk about seeking the appropriate care, so whether or not they're going to go to an ED versus the urgent care or their primary care provider, this is also whether or not they're going to finish out that antibiotic when they finally get it. We talk about antimicrobial stewardship. So are they just going to take it and then take it home? Are they going to take their insulins appropriately? Are they going to follow up with those things? If they do not have confidence in us and that what we're asking them to do actually has value and meaning, is going to lead to something, they're not going to do it and they're going to have poor health outcomes. So the key part for that is to call in that that's not just about their satisfaction. So not only are they going to be less satisfied, so they might go to the competition, but again, this really factors into how they experience and participate in their care. So articulating the return on investment. This has been something we've really been focused on, I know, across the board for a lot of us. So before we kind of get into this, I want to ask a quick question. Is everybody still following along? Are there any questions? Is everything making sense to everybody? Somebody can type in the chat box, yes, keep going, lady, or. Okay. Like I said, I want this to be more of a dialogue. I know the beginning part, there was a lot of the talking that's on there. So please feel free to put something into the chat or unmute yourself if the question is there.
Thank you, Gavin. Go, lady. We like that.
So here we want to talk about the potential real-life translation.
Hold on, I got a question. Is this going to be sent to us to reference to later?
Yes, so we are actually recording this, Wendy, and so you will have access to the recording, but we'll also send out a copy of the slide. So, and this is another thing, as we go through this, if you've got more questions, you want more support, we're here for that. So
I believe we're going to be putting this on healthcare communities.
Okay, perfect. So patient engagement can actually equal potential savings. We know that is what our practices are looking at. So I just kind of want to go through an example with you guys, and this isn't something that we go through. I mean, we've got our references here, so it's not just arbitrary. But the intention of this is to be able to help support people as they kind of process through. So let's look at one example for our practices. So say our practice has a complex or uncontrolled patient living with diabetes. We know that on average, an uncontrolled patient living with diabetes has an average of 2 emergency department visits. We know that they have a 10% chance of a 3-day readmission and an 18.2% readmission rate within 30 days. And the average inpatient facility charge for that patient is $43,000. So let's look at this from the first part. So if we are able, let's see if I can, click this. All right, so say that we're able to engage with our patients. We saw on that previous slide that they are less likely to have a readmission within 30 days. So they only had a 13% less, they had a 13% versus a 28% for less activated. So just one of those admits or readmissions, that's $43,000 just for one patient that we saved in that 1 year. So that's a lot of money, especially for our small rural independent system. But when we look at it across our entire patient population, it gets even bigger. So say we save that one admit, readmit for each patient among our patient population. So when we look at this, the average small practice panel, we kind of took some of those numbers to say about 1,300 patients. If we look at the national average for people in the United States living with diabetes, that's 9.4%. So that means that the average, practice empanelment, for a provider is about 127 diabetes patients. We know that our diabetes patients have about an 18% ED rate, so that's 23 patients. 42% of those have an admit rate. So of those ED visits, you know, we've got most of them that get treated and they get sent home, but 42% of them end up having an admission. That means 9.6 of our patients will actually be going through that for each one of those providers. So we have the opportunity to actually save almost $416,000 per year per provider, per empanelment for that provider that's on there. So that is where we start to see that actual figure when we're making that business case and we're going through that process with them, to be able just to lead them through those simple steps. The really cool thing with this is to be able to even sit down with them and say, okay, so how many patients do you have? How many of those have diabetes, are uncontrolled? How many of those patients had an ED rate? You can actually work with them to use their own real data for this. So we're going through and we're working on having very articulated, high level and things, you know, you can take those C-suites and things like that for that return on investment. But don't wait for those things. Make it real for them. Sit down and go through this process with them so that they can actually capture what this is going to bring back for them. So not only in patient things we talk about PFE, but when we have engaged patients, we also have an opportunity to increase potential revenue. And this is appropriate revenue. This is not just fee for service and getting them in there so that way we can bill for 15 minutes. But let's look at another example. So take a patient in need of complex chronic care. So how many of us are working with practices that have patients that are uncontrolled with whatever chronic condition that they have? And as they kind of go through that process, they only see them maybe one and a half times a year. So maybe they come to one of their chronic care appointments. The other time they maybe come in because they've got strep throat. We know best practice for chronic care management is 4 visits a year. And the average estimated payment we get for this office visit is about $83. And so that's based off of across a group of payers that are on there. So if we get one patient to receive the needed chronic care, that's $208 that we can bring into our practices. Now, if you were to put that across their patient population, so again, that same 1,300 patient empanelment number, you consider at minimum like 25% of those patients oftentimes have chronic cares. And if we can get them up to their needed 4 visits per year, that's an additional $67,000 that come into this practice per provider. So again, there's real return on investment, not just in terms of what we can save, but being able to support the care that we need by getting patients to those needed things. So our PFE metrics, when we go through this, offer us a starting point. So we all kind of know our metrics. We're familiar with those that are at point of care. So we know about the e-tool, we know about shared decision making, and all of those different things as we kind of go through them. The cool thing with these is they offer us a starting point. There's a reason for why we picked them. And when we look at our performance, so considering where we first started, so when we first looked at the metrics, November of 2016, this is kind of what we look like in through there. So you can kind of see that, you know, health literacy, patient activation, those were some of the ones that were a little bit further behind. Those had the bigger nose, you know, the e-tools, medication management, those things were ones that a lot of our practices were working on. When we did our last survey in September of 2017, you can see that again. These are the practices that are addressing, so responded yes or no, and you can see health literacy and patient activation, we're doing pretty well in those other ones, but there are 2 of these ones here that when we look at our steps to start, where we can support our practices, that we might have some lag there. And then I know we're in the current process as well for our surveys as well. So based off of what we received as of yesterday for that, you see this is a continuation as we go through it. So when we're looking at how we can enhance PFE for our practices, we started to kind of call out health literacy and patient activation. Those are the kind of the low-hanging fruit for us to kind of work with our practices and see where they're at and how we can advance that. And this is something too, wanted to make sure to call out to us on Compass PTN that this is hard. And the health literacy and patient activation are also the metrics as you look at this that other PTNs nationally are struggling with. These are sometimes the hardest ones for our practice to kind of switch and change some of the things up. They maybe didn't have those things in process yet. So we're going to work with them and we're going to work together on these 2 opportunities. So health literacy and patient activation. So are we assessing health literacy among our patients? And what do we do with that information once we do it? And then again, how are we assessing and measuring our patient activation? And again, what does that mean to us and what does that mean to our practices? So our PFE metrics, especially those 2, really offer us an opportunity to work with our practices on kind of that low-hanging fruit as they're working on some of those other components that factor in to their priorities across the board, including their clinical quality measures. So next steps, we again have kind of, this is part 1 of 4, so I'm going to let Jennifer take it over to kind of talk about what are our next steps and what we can anticipate over the next couple weeks together.
Great, thank you, Katie. That was a great overview of PFE. So as you can see, we have Friday, April 13th. We're going to feature health literacy. We'll be highlighting the different tools that can be used, and we'll actually be role-playing during our presentation on how to utilize those tools so everyone can see how much time it actually does take to perform one. So we'll be kicking that off, and then Friday, April 20th, we'll be doing patient activation, tools and highlighting of the skills and readiness ruler as well, and giving some pretty easy tools that can be implemented within the practices. And once again, we'll be doing some role playing. Lori Galeotto and I will be a patient and a health coach, so be prepared for our really great acting skills. We're going to win all sorts of awards with those. But Friday, April 27th, we'll be doing an overview of the implementation of PFE. So that's what you guys have to look forward to. I'm looking forward to it. I think Katie and Lori are as well. So if we want to open it up to any questions, comments, like we said, we'll put this on healthcare community. So you will see that there as well.
So I'm interested too. We kind of went through things kind of quickly, and we were going to go through and kind of have you guys kind of guess, especially for the return on investment for the, you know, when we were going through the calculations, have you say, okay, how much do you think it saves? What do you think that looks like? So looking at the return on investment, because I know that's where we've been all talking quite a bit, was that helpful? Is going through that process, is that helpful to know those figures and to be able to do that? What do you guys think? So, you know, because when we look at this too, we want your feedback as we look at, you know, the 13th and the 20th and the 27th, as we kind of design those and make them interactive. We want to hear from you. So now it's kind of the opportunity. So I'm going to put the challenge out to you guys. I'd like to hear from you. Was the ROI part meaningful to you? Were you surprised by how much do you think that those numbers aren't going to mean much to our providers? What do you think?
I think, just so everybody knows, I think most people are on mute. So if you want to unmute, feel free. If you want to type in the chat, that's fine as well.
I'm going to assume because it's so quiet, you guys are so excited and you're just typing out a big long paragraph. I'm just going to wait for it to pop up in the chat.
Okay. Great reminders, helpful. Great. Great.
I think the one really cool thing for us to remember is when we go through, we can break it down, like I said, rather than waiting, ask them as they kind of go through, because part of what we're doing is asking them to report their data and to look at it. So it also reinforces for them, number one, to report their clinical quality measures in through the portal, but actually have them go through and pull some of those figures and look at and go through those, calculations with them. And then again, those calcs that we had were based off of, per patient empanelment, so per provider, so the number of providers that they have. And collect great, it'd be strong with evidence of where the number of values came from. So that is actually part of what we're working on. So we're putting those different things together. And you saw that on there, we had some of those figures with the resources where we pulled that data from. So you'll see more of that, but we wanted to make sure to kind of talk to you about it before waiting for this, finalized document to come out. Because I think the stronger evidence of where the values come from can also be when we use their values. So because then it's that first person rather than saying, on average, this is what somebody else has on there. So again, just an encouragement that we're all on this curve together, and so to come along on the ride with us.
Great.
Okay.
All right, well, thank you everybody for joining us this morning. We had a great turnout. And we look forward to chatting with everybody next week. If you guys do have any questions, I believe, Katie, is your last slide our contact information? Mm-hmm. If you guys do have any questions or you want to follow up or you're not finding what you need on healthcare communities, please reach out to Katie, Lori, or myself. Our contact information is right here on our slide. And have a great rest of your day and a fabulous weekend, everyone. Thank you.
Thanks, everyone.